All right, let's jump right into a topic that you are definitely going to see on your high-risk obstetric anesthesia exams, managing sickle cell disease in pregnancy. This is one of those high-stakes areas, a real test of your skills, blending physiology, pharmacology, and critical care. But don't worry, by the end of this explainer, you're going to feel totally ready to nail it.
So, here's our game plan. We're going to walk through this just like a real clinical case, starting with the basic science, moving through assessment, management, and all the way to postpartum care. And you'll see, thinking about it this way is the perfect mental framework for when you're under pressure in an exam.
Okay, first up, what is sickle cell disease? Before we can even begin to talk about how to manage it, we've got to understand the root of the problem, right? So let's get back to the basic science.
You know, it all boils down to this one tiny inherited genetic mistake. A single amino acid gets swapped where it shouldn't be, and boom, you get this abnormal hemoglobin S. It's kind of wild to think that this one little molecular change is the root cause of every single problem we're about to discuss.
And here it is, the core of the problem, this nasty feedback loop. Think of it like a domino effect. Some kind of trigger, say low oxygen or dehydration, makes that funky hemoglobin start clumping together. That forces the red blood cells into that classic, rigid sickle shape. Now these sickled cells are sticky and they jam up the tiny blood vessels, which of course leads to more low oxygen and acidosis, which causes even more sickling. See? It just feeds on itself. It's a vicious cycle.
All right, so with that science in our back pocket, let's move on to the pre-anesthetic assessment. How do we apply this in the real world? Well, your job as the anesthetist is kind of like being a detective. You're hunting for clues of the long-term damage caused by years and years of this sickling.
So this is the big question you need to ask yourself. When you get that call about a pregnant patient with sickle cell, what are the key things you need to be looking for? What's on your mental checklist before you even walk into the room?
Okay, this table is pure gold for your exam prep. Think of it as your high-yield review. A few things to really zero in on. Under respiratory, any history of acute chest syndrome. That's a massive red flag. For cardio, you've got to look for pulmonary hypertension. Get that echo. It's more common than you might think in about 10% of patients. And hematology? Well, it's not just about the heme number. You absolutely, positively have to know their antibody status. That's non-negotiable for planning safe transfusions.
Okay, section 3. Now we're in the thick of it. Intrapartum and operative management. And, honestly, the whole plan, everything we do from here on out, comes down to one single overriding principle. Avoid the triggers. That's it. Our entire job is to stop that vicious cycle we talked about before it can even get started. If there is one number you tattoo on your brain from this whole explainer, it's this one, 94%. We need to keep their oxygen sats above 94% at all times. No exceptions. Hypoxia is the #1 trigger, so preventing it is our #1 job.
So your interop management is all about defending against these 5 key triggers. You got to keep the patient warm, no hypothermia, which causes vasoconstriction. Keep them hydrated, because dehydration makes the blood thicker. Obviously, keep them oxygenated. Prevent acidosis by making sure their tissues are getting enough blood flow. And finally, prevent infection, which is a huge systemic stressor. It's a constant balancing act.
So what about a C-section? Well, neuroaxial, so a spinal or epidural, is almost always our go-to. And the reasons are pretty compelling. You get way better pain control, and, this is a big one, the patient is awake. That means she can tell you if she starts feeling chest pain or shortness of breath, those early signs of ACS. The big trade-off? You have to be super on top of managing hypotension from the block. That means being ready with vasopressors like phenylephrine and warmed IV fluids.
Okay, so even when we do everything right, complications can still happen. When a crisis hits, you have to be ready to move and move fast. Let's talk about what to do.
And let's be crystal clear about this. Acute chest syndrome, or ACS, is a full-blown medical emergency. It's one of the leading causes of death in this population. You can think of it as an acute lung injury, often kicked off by an infection, a fat embolism, or even just hypoventilation after surgery. Your index of suspicion has to be sky-high for any patient with SCD who develops a cough, chest pain, or gets short of breath.
When you suspect ACS, you need to act immediately. Here are the investigations you're ordering right away. And here's a key exam pearl. The chest x-ray can look totally normal in the beginning, so you do not wait for the film. You treat based on your clinical suspicion. That means starting broad-spectrum antibiotics, getting them on oxygen, managing their pain, and getting on the phone with hematology and critical care right away.
This naturally leads us to talk about blood transfusions. But listen, this isn't your standard top-up for a low hemoglobin. The quote here says it all. Transfusions in this group are complex. You must discuss them with the hematologist. This is not something you decide on your own.
And here's why. When we do an exchange transfusion for something really serious like ACS or a stroke, our main goal isn't just to raise the HP number. The real goal is to dilute the bad stuff, to lower the percentage of that faulty hemoglobin S. And the magic number we're aiming for, we want to get that HPS level down below 30%. That's the critical target.
And this slide is exactly why you have to call hematology. These patients have often had many transfusions before, so they can have all sorts of antibodies that make finding compatible blood a nightmare. This puts them at a huge risk for reactions, including the one we all fear, hyperhemolysis. This is a total catastrophe where the transfusion actually triggers the destruction of all red cells, both the new ones and the patient's own. It's why they need special, super-matched HBs-negative blood.
Here's a little pro tip for your exams. If you want to really impress, dropping the names of a couple of key trials shows you've gone the extra mile. The TAPS-2 trial looked at whether giving transfusions proactively in high-risk pregnancies helped, and it suggested it might. And the HOPE study was a big deal for a drug called voxelotor, which is cool because it works by stopping that initial sickling process right at the source.
All right, last section, but don't relax just yet. The danger is not over once the baby is out. In fact, the first few days postpartum are an extremely high-risk time for a painful vaso-occlusive crisis. You've got to stay just as vigilant now as you were in the operating room.
So here are your postpartum priorities. First, these patients need enhanced monitoring. We're talking a high-dependency unit. Second, you have to be aggressive with pain relief. Leaving an epidural in for a day or two is a fantastic option. And finally, you have to be proactive about preventing other problems. Get them using an incentive spirometer, get them moving, and make sure they're on reliable thromboprophylaxis.
So, to wrap this all up, let's come back to this question. What's the secret to a good outcome here? It's all about planning. A solid, multidisciplinary care plan that's made before the patient is even in labor. Getting obstetrics, anesthesia, and hematology all on the same page ahead of time is what makes all the difference. It's about being proactive, not reactive, and that's what saves lives.
And just so you know, the information in this explainer came from 2 really fantastic review articles. They're listed right here, and I'd highly recommend you check them out for some deeper reading before your exam. Thanks for tuning in.